All right. Hello, and welcome to today's case presentation, Stress and Cortisol in a Hypertensive Patient. I'm Dr. Allison Smith, one of the clinical educators here at Dutch, and I am super excited to share this case study with you today. We have a medical disclaimer here before we get started. This case study and all the slides that follow are all just provided as health information resources and should not be taken as medical advice. That's our medical disclaimer here if you want to read through that. Today's agenda will talk mostly about a postmenopausal Asian female patient on several blood pressure medications with the goal of improving her cardiovascular risk. That's really what she wants to do. And my goal today is to review a little bit about hypertension, because I think it can be a sticking point for some people. You kind of get caught up in, the prescription guidelines, and sometimes we don't really think very far past that. And those of us who are providing care around the edges of patients who are on medications already, this can be really helpful information to know how to manage these types of patients. So I want to review a bit about hypertension, but also some of its contributing factors that we can maybe control and help people control through lifestyle supports. And we'll use that information to frame a conversation about what you might expect to see on a Dutch Complete for a patient on a diuretic medication. So here's a little preview of our case before we dive in fully. So we're going to work with a 68-year-old Asian female patient, I told you, but she's presenting with obesity as well as hypertension. And like I said, her goal is to improve her response to her blood pressure meds. She would maybe like to eventually get off of some of these meds, really kind of work toward deprescription in a systematic way. She's currently on Exforge, which is a mixture of 3 medications. One is a calcium channel blocker, amlodipine. Losartan is an ARB, or an angiotensin II receptor blocker, and HCTZ is a good old-fashioned diuretic, and all combined together. And then Lipitor to help control her blood lipids. She doesn't have a lot of complaints, you'll notice. She feels pretty good, but she does have some mild fatigue that she attributes directly to those blood pressure medications when she started them. So before we unpack the case, I really quickly want to review hormone physiology of hypertension, because it can be a little overwhelming because there are many systems that kind of play together, but all of these systems come together to control blood volume and our vascular tone. So how constricted are our blood vessels, and how big is our blood volume? How much blood do we have pumping through the bloodstream? Is it full of fluid? It's going to raise your blood pressure. And if we're excreting sodium like we should, it's going to be less expansive, and your blood pressure is going to come down. So in some ways, we're dependent on how much fluid's in the system and how hard those veins and arteries are that are kind of pushing on that blood volume. So here's my probably oversimplified process here, in my mind when I think about endocrine and neuro influences on blood pressure. But essentially, acute stress. So here's our little stress bubbles. I'm going to get a little laser pointer here. Laser pointer. Stress, stress, stress affects all 3 areas here pretty predictably. Chronic stress can also have a negative effect on cardiac and endothelial structure and function kind of directly, but also through influence on these 3 systems. And that changes our baseline cardiovascular resilience. So successful modulation of stress is super important. I mean, as you can imagine, to long-term maintenance of cardiovascular health. And I'm not going to go into the nitty-gritty of how the renin, angiotensin, aldosterone system works exactly, but essentially, as angiotensin 2 goes up, we retain sodium and water, and our blood volume goes up. Our blood vessels constrict. So it really works on both systems. There's direct influence on our electrolyte balance and also on our vascular tone. And you get a net increase in blood pressure So we need controls or inhibitors for both angiotensin activity and aldosterone synthesis. So both aldosterone and angiotensin are going to cause us to hang on to sodium and increase the blood volume and our blood pressure. Um, Estrogen receptor activity is one control on aldosterone and angiotensin 2. So, when we're premenopausal, we're stretchier and rubberier, and we're, hopefully excreting more sodium. Healthy electrolyte balance, of course, is another modulator. And of course, stress we can see is a huge modulator. If we're good at managing our stress levels, our RAS system is going to be downregulated. Notice also that we have a sympathetic nervous system component here that actually works on all of these systems. This is where we have rises in norepinephrine and epinephrine or adrenaline when we're acutely stressed, we're running from the tiger, or even more often we'll see inappropriate diurnal rhythms of norepinephrine and epinephrine. You don't necessarily see this high, acute stress running from the tiger all day long for everybody, but you might see high norepinephrine, epinephrine, even metabolism during the night while somebody's asleep. And that can drive, blood pressure elevations and cause metabolic syndrome, essentially. We see this sometimes in sleep apnea patients. But either way, those norepinephrine increases can increase RAS activity over here in the kidney through that beta adrenergic stimulation there. It can also stimulate cortisol production directly at the cortex by engaging with alpha-1 adrenergic receptors. And it can also act kind of directly in the kidney by interacting directly with our constricting blood flow to the kidneys. I mean, it's acting in all areas. You can imagine, patients who are on beta blockers or medications that act directly on the sympathetic nervous system, they're really at risk if they come right off of their beta blockers and all three areas, sort of legs under that stool, are kicked out. They can really have a serious problem with rebound hypertension. So that's a really important system to know about if you have patients on beta blockers and you're working to deprescribe. That's a pretty strong system to be withdrawing medication from. So to do that per guidelines if you can. High cortisol, and this is the third one over here. We know from cortisol excess patients, like Cushing's patients in particular, they present with hypertension as really a key component of their disease process. And it increases blood pressure by a number of different mechanisms. High cortisol in the context of low DHEA, I just want to kind of posit some of this information here. There's this concept of arterial stiffness that, we have a stiffening of the arteries that happens as we age. And I might have a slide on that. Actually, it's the next slide. Yay. A note about arterial stiffness. There are some hormonal influences, and we think about sex and adrenal hormones here. It's definitely related to age. It's related to menopause, the drop in androgens and the drop in estrogens. And of course, high blood pressure can contribute directly to arterial stiffness. But I think when we're looking at the Dutch test and we're assessing sex hormones and we're assessing adrenal hormones and all of those different inputs, this is really where estradiol and DHEA, at least in part, fit into that picture. So when DHEA drops with age and cortisol rises with chronic stress, that's kind of a magic combination, especially in the context, if you think of low aerobic fitness. Maybe you have a sedentary time in your life when you have high cortisol and your DHEAs are dropping naturally, your arteries become less flexible. And so now DHEA supplementation has been helpful in partially reversing some of that arterial stiffness in randomized controlled trials. There's one in that box right here, I think they were using 50 milligrams of DHEA to reverse that arterial aging. But I thought that was really interesting. And then there was another study, it's called the SWAN study, SWAN, SWAN Heart Study. They looked at low estrogen combined with high FSH in perimenopausal patients who are kind of transitioning over into menopause. And they found that that perimenopausal transition with the low estrogen, high FSH actually is related to arterial stiffness and correlates strongly with that progression that adds on top of your sort of age-related progression. And it's especially pronounced in the first year of menopause. And there are some cohort differences to be aware of too. If you see a lot of Black female patients, for instance, this is a really important time window for those guys because you see even more pronounced arterial stiffness in that first year of menopause. So early interventions are really important in that cohort. It's important in general, but I think, in that particular cohort, we want to really be specific with our timing and not miss their window for prevention. So here are some of the systems targeted. It's a little bit of a busy slide, but it gives you some idea of some of the blood pressure medications and where they act. So you can see ACE inhibitors and ARBs over here, and I put estradiol here too because it is an ACE inhibitor, essentially. They have their effects mostly on the RAS system. Beta blockers work up here to decrease your sympathetic tone. And of course, all of the lifestyle modification supports, stress controls, insulin controls, inflammation controls are all going to decrease your cortisol activity. Now, loop diuretics and calcium channel blockers, they act a little bit more directly, so they're not working through any of these top three systems. They're really working on lowering blood pressure. The calcium channel blockers act directly at the vascular tissue and cardiac tissue, bind at calcium channels and decrease the vascular tone and resistance that way. And the loop diuretics actually go in and work directly in the kidney to increase excretion of sodium. So very direct effects from those guys. So I just kind of put them down here. So just to recap in a list form, the main systems implicated in blood pressure management in the body, these systems all compete for net effects on vascular tone and blood volume and influence our electrolyte balance. So you can affect one system will kind of loosely and indirectly affect the other. And notice that there are many lifestyle modifiable drivers of cortisol. So, we can control these pretty tightly for some people and really make a big difference for their blood pressure over time. So I want to focus today mainly on cortisol. It's easy to pull in other parts. The Dutch test is kind of a holistic test. It's really hard to just drill in on 2 or 3 important markers without really pulling in the whole thing. And that is the beauty of the test. But I do want to focus on cortisol and its metabolism and what we expect to see on the Dutch when a patient is using diuretics in particular. But first, we should make sure we have a good understanding of the enzyme that's converting cortisol into cortisone, 11-beta-HSD type 2 in the kidney, and of course 11-beta-HSD type 1 in the liver and adipose tissues. So here's 11-beta-HSD. It's actually an enzyme family, and there are a couple of different forms. The 11-beta-HSD2 enzyme is converting cortisol to cortisone in the kidney. And in the liver and adipose tissue, we have 11-beta-HSD1 that's highly expressed, a little bit of 11-beta-HSD2, but not much in the liver and adipose tissue. And mainly we're getting, that back and forth conversion of cortisol, cortisone there from 11-beta-HSD1. And then from the liver and adipose, we do get generation of these metabolites of cortisol, tetrahydrocortisol and tetrahydrocortisone, THF and THE, which we do measure on the Dutch test, and you are able to get a sense of how much cortisol production is happening in the liver and adipose tissue. So that's important to know outside of that kind of HPA axis direct control. There's that 11-beta-HSD2 activity in the blue box there. This is happening in the kidney, salivary glands, GI tract, everywhere where we're making an end body fluid that needs to control fluid balance, fluid in, fluid out. You're going to find it in those tissues. And of course, 11-beta-HSD2 excuse me, 11 beta HSD1 in the liver and adipose tissue. That's the one with the double-edged arrow. That's the one that gets upregulated in obesity and inflammation, and we can get some pretty big, huge cortisol metabolites numbers on the Dutch test when we have a lot of inflammation. So that's an important information enzyme to know. Okay, cortisone is formed locally in the tissues from cortisol, especially in the tissues that are forming our end body fluids, remember. So this is 11 beta HSD2, one-way arrow, cortisol to cortisone. When we're measuring cortisone in the urine or in the saliva, we know that much of that cortisone was formed locally from cortisol after entering the kidney or the salivary gland from circulation. You know, the cortisone does not have a diurnal rhythm, but it does in the urine, it does in the saliva. Why? Because that local conversion in the gland on the way into the urine, on the way into the salivary gland, into the saliva, that's what's creating that diurnal rhythm. Okay. And as such, it's an additional measure of circulating cortisol levels, especially in patients with a high 11 beta HSD2 activity, like patients on blood pressure meds. Okay, that's why we're talking about this. So 11 beta HSD2 is here to protect our mineralocorticoid receptors from cortisol, right? If you're binding mineralocorticoid receptors with cortisol, then you're going to engage all of that sodium retention and blood pressure and blood volume expansion that we want to avoid in chronic stress, right? So you might notice that cortisol looks an awful lot like aldosterone. So you get a lot of that direct activity in the kidney from cortisol. We want to really protect ourselves from that, those blood pressure spikes if we can. And that's that enzyme's responsibility. So patients with high 11 beta HSD2 activity in the kidney or the salivary glands may have low free cortisol. So I want to just introduce this concept that you might have a patient who has this low, flat, free cortisol rhythm, but when you go to look at their free cortisone pattern, oh, well, it looks much more normal. The important takeaway here is that you wouldn't treat this patient for low cortisol production or not having a diurnal rhythm. You know, in fact, there's normal cortisol in circulation reaching the kidneys, but that kidney is upregulating the conversion of cortisol to cortisone. And diuretic medications, especially ACE inhibitors and ARBs, they yield this 11 beta HSD2 upregulation. And of course, we're expecting to see this picture, very normal. You know, they're blocking angiotensin 2 activity. And remember, Ang2 slows 11 beta HSD2 when it binds its receptor in the kidney. It's the AT1 receptor, and it's going to slow down 11 beta HSD2 activity. You also can see this pattern naturally in obese patients or patients who have electrolyte imbalance. You might see, you know, a push over into the cortisone metabolites, but definitely on the diuretic meds. So what if you do a Dutch test on a patient treated with an ACE inhibitor or an ARB, and they come back with a high urinary free cortisol compared to a free cortisone, like this one? So, you know, let's say this person is on, you know, lisinopril or losartan, and you would expect to see the free cortisol kind of low and flat and the free cortisone to look much more normal in a normal patient. You might think, well, maybe their medication isn't working. And I think you'd be kind of on the right track. And there have been studies that have asked this question, and they're a little bit all over the place. There are some that say, yeah, it's a sign of treatment-resistant hypertension. Others will say, well, not so much across the board. There was a poster that came out in 2019 that found that high 24-hour free cortisol may be a sign of primary aldosteronism. If you're on a diuretic, you're on an ACE inhibitor, you're on an ARB, and you still have this high free cortisol, that could be more a sign that the aldosterone's an issue that's not being addressed. And primary aldosteronism is one of those diagnoses that may affect up to 10% of our hypertensive patients. I think it's something that's been in the past quite underdiagnosed. So if you see patterns like this, it might make you think, well, you know, if we're not super well managed on, on these medications, that maybe there needs to be some further workup, possibly. And this is really the high 24-hour urinary free cortisol that we're talking about, possibly with primary aldosteronism. Okay, what about 11 beta HSD1? That was 11 beta HSD2 happening in the kidney. But 11 beta HSD1 is an enzyme that's highly expressed in liver and adipose. Just try to keep liver, it's like two different compartments of cortisol utilization, kind of doing different things. So it's expressed in the adipose tissue. So if you have somebody with a lot of adipose tissue, they may have a lot of cortisol metabolism and a lot of metabolites of cortisol in the urine. In fact, this study down here, this Ingley study, found that 11 beta HSD1 expression was found to be twofold higher in adipose tissue. So it's significantly higher. And 11 beta HSD activity generates cortisol and cortisone, and they're then metabolized down into THF and THE. So you might hear me refer to tetrahydrocortisol and tetrahydrocortisone as THF and THE. They're kind of a mouthful. What else do I want to tell you about THF? THF in particular, but also THE in the urine increase as 11 beta HSD1 increase. So we think about high cortisol metabolites in general as being associated with high 11 beta HSD1 activity. And sometimes we'll talk about them kind of interchangeably. 11 beta HSD1 activity, I guess the other thing I wanted to tell you is that that's an enzyme that's upregulated in omental fat and visceral fat, more so than sub-Q fat. So it really kind of depends on where that fat is. And I think that's why there's a real connection between high cortisol metabolites in the urine and waist circumference and with leptin resistance. So sometimes we'll go in and test leptin and assess for leptin resistance in patients with high cortisol metabolites and an elevated waist circumference. All right. The conditions associated with high 11 beta HSD1 activity are really those of cardiovascular disease and inflammation, really metabolic syndrome. Our patient we're looking at here, is dealing with hypertension and obesity. So we're kind of expecting to see a shift of free cortisol into free cortisone. We're expecting to see, maybe some elevated metabolized cortisol. And these are all things that you should maybe have in your mind when your patient with hypertension and obesity is sending in their Dutch test and, check for that when those results come back. Now, okay, so we know the basics of what to expect. I want to just throw in just a couple little examples just to kind of cement this in, and I want these to be really easy for you to spot. So here's example one. This is a female patient who is 69 on a calcium channel blocker, so verapamil, and she's doing 100 milligrams of losartan. And remember, losartan has its activity blocking angiotensin II receptors, or AT1 receptors in the kidney. And because angiotensin II decreases 11 beta, because angiotensin II decreases 11 beta HSD2 and causes us to hang on to cortisol and raises our blood pressure, blocking those AT1 receptors, there actually results in a net increase in 11 beta HSD2. So we're blocking the thing that blocks 11 beta HSD2. So this is the net increase. We get lower free cortisol, we get higher free cortisone. Doesn't necessarily mean that she's low in cortisol. That would not be the assessment, right? She's simply got a strong 11 beta HSD2 activity that's inactivating cortisol to cortisone in that mineralocorticoid receptor rich tissue, the kidney, that's controlling her blood volume. So let's look at the next one here. 46-year-old female patient using lisinopril. So this is not an angiotensin II receptor blocker, but it's an ACE inhibitor. So it's inhibiting the converting enzyme that makes angiotensin II. So free cortisol is significantly lower than free cortisone. In fact, you can check the dials underneath the graphs. You can see them pointing to each other. That's a pretty significant finding, right? But expected, right? She's on lisinopril. And this is the curve we have to look at. Last one. This is a male patient, 75. He's on 100 milligrams of losartan. That's the angiotensin receptor blocker. You can see him totally flatlined. If you only looked at the free cortisol pattern, you'd be treating him for HPA axis dysfunction. It looks terrible. But you can see his free cortisone pattern looks much more robust. You might be thinking about things in a different direction. Well, this is a pretty excited cortisol response initially in the morning, and he may have pathology associated with that, and certainly wouldn't be low cortisol. So let's get back to our case. Knowing all of that and keeping that in our minds when we get to the adrenal page 5 on the Dutch complete for this patient. But here we have a 68-year-old Asian female. Remember, she's presenting with obesity and hypertension. Her goal is to improve her cardiovascular health. She wants to be preventive. She wants to get off of her meds. In the long term, they make her feel tired. She is on that combo of calcium channel blocker, ARB, and a good old-fashioned HCTZ diuretic, and Lipitor for her blood lipids. She does eat an omnivore diet. She has an irregular exercise schedule, and admits it's pretty sporadic. Her blood pressure in the office was 140/90 on those 3 medications. Most of her labs were pertinent negatives, actually, or were negatives. A lot of normal limits. Lipid panel looked good on the statin. Her blood sugar looked fantastic. Electrolytes were all within normal range on her diuretic therapies. The only thing that was really remarkable and stood out was an elevated hsCRP. And the provider on this one decided to order a Dutch complete as part of her initial workup. And here's the summary page 1 of the Dutch complete, where we get a little preview of what's to come deeper in the report. E2 is within the postmenopausal range there in that purple band on the dial. But remember that postmenopausal female levels of estrogens can contribute to engagement of angiotensin 2, right? That drop of estrogen from premenopausal levels to postmenopausal levels definitely contributes to angiotensin 2 activity. Like, we don't have our natural ACE inhibitor on board anymore. Progesterone's lower than we'd expect, even for postmenopausal female. And there may be an association between low allopregnanolone, which is a further down metabolite of progesterone, and maybe an inability to engage GABA receptors, which are inhibitory. We need that sort of disengagement of our sympathetic nervous system and downregulation of, glutamate and norepinephrine and epinephrine. GABA is such a modulator of epinephrine release from the adrenal medulla that, for your allopregnanolone activity is low, you might run higher in the sympathetic nervous system activity than the average bear. So that may be remarkable, actually. We've also got a super low testosterone, and as this patient is of Asian descent and the testosterone is less than 1, we're suspecting that she has a deletion in the UGT2B17 gene. In these cases, testosterone does not enter the urine in a way that correlates with serum circulating testosterone. So it's pretty simple. Usually with patients who are premenopausal or male patients, you can eyeball a testosterone to epitestosterone ratio. But in postmenopause, when you have a really low ovarian output anyway of testosterone to begin with, and that's really where most of your epitestosterone is coming from, it's harder to make that assessment. So we recommend testing testosterone in serum in postmenopausal patients with low urinary testosterone, even if epi-T is below range also. And that was the case with her. I think her epitestosterone was 1. It's still higher than the 0.2, but I think that together with her Asian background and the testosterone being less than 1, I think that's enough to go ahead and default to testing in the serum. Just make double sure that that matches up nicely before starting any androgen replacement, certainly. Then when we get to the adrenal hormones, DHEA doesn't depend on UGT2B17 to enter the urine, so we are still able to assess those DHEA and its metabolites, and they are low normal. She very well may be low in testosterone, just given her DHEA being at the bottom of the range. But I think it's interesting that her cortisols are so high. We were kind of expecting to see elevated metabolized cortisol, just given her, her history. She's dealing with obesity and she has hypertension. It's not unusual. And that high HSCRP, I mean, we're certainly expecting to see some higher metabolized cortisol, and we are. And of course, free cortisol pattern, high normal through most of the day, and then she takes a jet upwards at night before bed, which is an odd time to come up. So here's page 3 of the Dutch Complete, and this is the sex hormone page, and we can look through some of the metabolic patterns and tendencies and get a sense of, maybe contributing factors to metabolic preferences. So let's start up here in the top right corner with the progesterone metabolism. And remember, progesterone itself isn't measurable in the urine, but the 5-alpha and the 5-beta reductase metabolites are. And for her, the 5-alpha pregnenolone is very low. You can see that falling below the little purple band, which is the postmenopausal range on our dials here. For me, that suggests a lower formation, like I said, of that endogenous GABA receptor ligand. And a lot of our 5-alpha products are very active at the tissue level. So, if she doesn't have a lot of this potential for GABA A binding, she may not have enough inhibitory activity to control her sympathetic tone and blood pressure on her own. Here are those estrogens. They're within normal postmenopausal ranges. These are your parent estrogens, estradiol and estrone. Those look okay. They're low compared to premenopausal levels, right? Because she is postmenopausal. The premenopausal levels are between the stars up here. And that's really where we get a lot of that nice angiotensin II blockade. So some people would look at this and say, well, let's consider estrogen replacement therapy, and there are studies to support that. She's almost 20 years out of going into menopause, and so I think the questions or the conversation starts to change a little bit once we're that far out, and the presence or not of estrogen receptors in the vascular tissue starts to become questionable at that point. But if you're early enough, I think estrogen replacement therapy can be a nice consideration for helping to prevent some of those changes in the vascular system. So when we look at her metabolism, we see she's got a lot of CYP1B1 activity. In fact, 18.3% of her metabolism is dedicated to forming these 4-hydroxyestrogen metabolites. And that's too much. And we know this pathway is induced by inflammation. We're kind of not surprised to see that. And that's something we can monitor as we get on top of her inflammation, and hopefully her HSCRP will come down, her CYP1B1 activity will come down, and she'll be in a good position. And that brings us to her phase 2 metabolism of estrogen, which we can see trends high. There are numerous studies actually on the COMT gene variants, several different ones, and risk of hypertension, and even studies that have looked at treatment of hypertension and response to different medications with different COMT SNPs. But generally speaking, a slow COMT is associated with higher blood pressure. But those fast COMT variants with high blood pressure, they tend to respond to calcium channel blockers better. So if you're prescribing to a patient with a known genotype of COMT, that might be something to dive into the medical literature before prescribing. If you're not familiar with some of those studies, they are out there, and you can get really particular with your treatments for those patients. But there is kind of a counter argument to the fast COMT type being better for blood pressure. There are still patients who do end up, even with a high COMT activity, with higher systolic blood pressure in particular, and those patients tend to be low estrogen patients, so even lower than you might expect for postmenopause. And I think the the high COMT activity is, yes, it's clearing out some of that high sympathetic tone, metabolizing norepinephrine and epinephrine down and helping that way. But if you're clearing your estrogens too fast, you're losing some of that protective effect from the estrogens possibly. But it's an interesting, balance to think about. And of course, the green section here details those low androgens we saw on the summary page. Don't forget to test the testosterone in serum to confirm the low there if you're considering testosterone replacement therapy. Which brings us to adrenal page 5, where we find a slightly deeper dive into the cortisols and the cortisol metabolites. There we go. And we see the balance between free cortisol and free cortisone is weighted back towards cortisol. That's not supposed to happen, right? That's an odd finding for someone on an angiotensin II receptor blocker. So if the patient's blood pressure is higher than you want it, despite being treated with 3 meds, this could be a sign. This cortisol, this imbalance toward cortisol, could be a sign of, an underlying pathology. Is it aldosterone and we need more like a loop diuretic instead, or is it acute stress? Is it an infection? Is it inflammation? There are other things that could be kind of on board and driving some of that, acute, free cortisol presentation. All right, when we assess DHEA, we see that it's low normal compared to pretty high free cortisol. And we think about that relationship with arterial stiffness. And of course, we have our high metabolized cortisol, and that's suggestive of high 11-beta HSD1 activity that we see in obesity, stressed patients, and inflamed states. All right. This is our oats page here. Dysbiosis kind of has an interesting link to hypertension. It's not totally teased out whether it's a chicken or egg thing, but hypertension is associated with high lactobacillus and Akkermansia, low levels of bacteroidetes. Hard to keep them all in your brain, but low in butyrate generating species as well. So I think about, when somebody has an elevated indican here, we think about dysbiosis, especially in hypertension, but we don't know necessarily if hypertension caused the dysbiosis or if dysbiosis is leading to hypertension. There is kind of an argument in the medical literature, a little bit back and forth about that. Outside of dysbiosis, I think a little bit about hypochlorhydria and protein malabsorption, especially in this age group. As we age and get older, our stomach acid becomes a little bit more basic. So think about protein malabsorption, especially in the context of B12. I guess that's what I wanted to say about B12 deficiency. If we're not making the stomach acid that we need, we may not be making the intrinsic factor that we need, and that can make it difficult to absorb and utilize the B12 that we're getting in our diets. All right. Lower HbA stands out for anyone struggling with hypertension or obesity, both. Dopamine activity in the kidney corrects fluid imbalances and blood pressure. It's like one of our big regulators of sodium excretion or reabsorption. And of course, in the brain, dopamine hones our focus and motivation and sense of well-being, and is often used in, it itself isn't used in weight loss, but supplements that support dopamine synthesis, like mucuna and tyrosine, are often used in weight loss. Quin-kine ratio is high, and that's suggestive of an inflammatory underpinning. We already saw some inflammation earlier on the test, so it's not really a surprise. This ratio is often higher in patients with cardiovascular disease and hypertension, and should improve as you can move some of that inflammation out. And of course, melatonin, when it's low, suggests poor sleep quality or possibly sleep apnea for some patients. Melatonin treatment studies in hypertensive patients suggest that taking melatonin before bed each night lowers nocturnal blood pressure. So it could be a consideration for controlling nocturnal. So here's her initial assessment, which is essentially that most of her symptoms may be attributable or at least associated with inflammation and possibly an imbalance in the inhibitory GABA system. But remember, all those little associations between arterial stiffness and that low DHEA, high free cortisol, and really kind of thinking about some of these hormones in relationship to the others. As far as the treatment plan is concerned, this provider was considering an anti-inflammatory protocol to address the main theme of all the findings on the Dutch test. So they were really trying to put together, the main area of focus. And there are many options that can be tailored to an individual's needs, from dietary interventions to herbal anti-inflammatories. This provider decided to intervene with an AIP diet first, and then consider transitioning to a fully plant-based diet after the initial treatment plan and initial assessment when she comes back in 12 weeks. They also began an anti-inflammatory herbal formula. I actually included a short list of some of the more well-studied anti-inflammatory plant medicines that cross over into metabolic syndrome territory as well to consider. But I think they chose to do curcumin, 2,000 milligrams, and but you can do combos of these things, and there are many ways to support inflammation with supplements. They were not considering doing HRT due to the patient being 68 and having been in menopause for almost 20 years already. And the patient's preference was to avoid prescription hormones if she could. They did intend to use oral DHEA, and she seemed to be okay with that. And they really wanted to try to improve arterial elasticity. I think they were encouraged by some of the studies in elderly patients and, increasing arterial flexibility and their effects on blood pressure. So the goal was to get up to 50 milligrams like the study, but they started with a 10 milligram. Melatonin was added to the regimen for its anti-inflammatory effects, as well as for that nocturnal systolic and diastolic blood pressure lowering ability. And remember, or maybe you don't know, but calcium channel blockers increase the clearance of melatonin. So that might increase dosing requirements if you're using melatonin for somebody with a calcium channel blocker. So I think it's also important to know, too, that beta blockers can actually decrease melatonin output. So whenever you have somebody on a medication cocktail that you're not super familiar with, it's always good to see, how it affects melatonin before you put somebody on it, so you know what to look for when you're doing, retesting and when you're assessing the patient after they're on. An adaptogen formula was implemented, one that has many of the adaptogenic herbs that also have the ability to engage GABA receptors. So yes, it's an adaptogen. It works at the HPA axis. It lowers cortisol, but also it has inhibitory activity at the GABA receptor as well. So affects sympathetic nervous system and HPA. And those are things like ashwagandha, relora, lemon balm, chamomile. They chose a formula that had all of those in there, and some GABA. And I think that was based on a study that looked at 80 milligrams a day of GABA, decreasing blood pressure. And I think, there's a back and forth conversation, mostly outside of the medical literature, but there's this idea that, if you can't get GABA across the blood-brain barrier, then what's the point? And I think the point is that there are GABA receptors all over the body, and there are especially GABA receptors in the adrenal medulla. And GABA receptors activity is quite responsible for modulating norepinephrine and epinephrine release from the adrenal medulla, and all of that, peripheral sympathetic activity that comes from that can be stemmed with GABA. So I think that is the rationale that we're kind of going with. Let's see. Lifestyle recommendations. So The lifestyle recommendations they ended up going with were to try to implement an aerobic regimen of some kind every day. And it didn't have to be the same thing every day. It could be brisk walking, it could be swimming, it could be dancing. The idea was to get the body in the habit of moving every day. Um, because of the lower melatonin and the higher cortisols, hypertension, obesity, they were also considering a referral for sleep study to rule out sleep apnea. Um, sometimes it's helpful to administer, a stop bang or an Epworth sleepiness scale questionnaire, just to get a sense. But this particular patient lived alone and she wasn't aware of any snoring, and she feels okay in the mornings, just a little bit fatigued all day long. So she doesn't, exactly fit all the criteria, but she does, deal with the disease of obesity, and she does have the hypertension. And she's not super well controlled, and it may be worth digging around a little bit in sleep. And finally, they did decide to shelve stool testing until a follow-up Dutch test is done in 3 months after that. Initial interventions are on board. And the idea would be, if the indican was still high on the Dutch test, that they would maybe do a more comprehensive stool test where they can look at, markers of pancreatic function and protein absorption, and also, commensal and opportunistic overgrowth organisms, and figure out, if there's, some dysbiosis there, and treat the gut. And I always like to drop some references in. This is always my last slide, that you might find informative for honing your thought processes and creating your protocols. Many of them are open access publications, so you can read them in their entirety. So enjoy if you're interested. And that concludes our case. I hope you found some of this helpful as you approach your own hypertensive postmenopausal patients. And thank you for being here and learning with me today.